Welcome to podcast 18 of Let's Revise MBBS, and our today's topic is Rh negative pregnancy. So in Rh antigens, the most important antigen is the D antigen, right? So if the D antigen is present, it will be Rh positive. If it's absent, then Rh negative. Okay, so there are four possibilities between mother and fetus. Mother can be positive, fetus can be Rh positive. No problem. Mother can be positive, fetus can be negative. Again, no problem. Mother can be negative, fetus can also be negative. Again, that's okay. But if mother is negative, mother is Rh negative and fetus is Rh positive, then there might be a problem. But why? Why is this a problem? Because, let's see. Now, fetus has Rh positive RBCs, mother has Rh negative RBCs. So, mother till now was never exposed to Rh antigen, but this fetus is having Rh positive antigens, right? So these RBCs obviously will not cross the placenta and go into the mother during the time of pregnancy, but when there is delivery happening or any time during the pregnancy, if there was any sort of trauma, some amount of blood from the fetus is going to leak into the mother's blood or mother's blood vessels. Okay, and these are Rh positive RBCs, and this will stimulate response. So the mother's immune system will start forming antibodies against Rh antigen, against the D antigen, right? Initially these are IgM, but later they get converted to IgG antibodies. But till this time the fetus is already delivered, right? So even if the antibodies are formed, it's not going to harm the first baby. Okay, but the problem is when the second baby, when she conceives the second time, she's already having antibodies against Rh antigen, and these are IgG type. So when she conceives next time, and if the fetus is Rh positive, these antibodies can cross the placenta and affect the second fetus. Okay, that's why mother Rh negative and fetus Rh positive can be a problem if we don't intervene. So what should we do? The first step, if the mother is Rh negative, the first step is to check the husband's blood group. Check whether he is positive or negative. If he is negative, no need to worry, because negative, the fetus is going to be obviously negative. But if the husband is positive, we need to consider that fetus is also positive and do the next workup accordingly. So now if the husband is positive, we do the second step, which is ICT, indirect Coombs test. Okay, this we do to check if there are any antibodies present in the mother. So ICT can either be negative or positive. Most of the time it is negative. Why? Because mother was never exposed to D antigen, right? So most of the time the ICT is negative. So if it is negative, it means that mother is not having antibodies against Rh antigen, so it is a low risk pregnancy. If ICT is positive, that means that the mother is already having antibodies against the D antigen, and that pregnancy is known as high risk pregnancy. Okay, now first we will see the management of ICT negative pregnancy. So if the indirect Coombs test comes out to be negative, then that patient is called as category 1 patient. For these patients, we give anti-D antibodies at 28 weeks, and the dose of this is 300 microgram, okay, which is also equal to 1500 international units. So 1 microgram corresponds to 5 international units. Okay, so why do we give this at 28 weeks? Actually, this is a prophylactic dose. In case there is any mixing of blood from fetus to mother between 28 to 40 weeks or between 28 weeks to time of delivery, then it will not stimulate the mother's immune system. Rather, whatever anti-D we are giving, that will destroy the D antigen or Rh positive RBCs, and the mother's immune system will not be stimulated. So at 28 weeks we must give these anti-D antibodies, and the second dose is given after delivery. Okay, so after there are highest chances of mixing of blood after delivery. So anti-D is to be given within 72 hours of delivery. again the dose is same, 300 micrograms. Okay, in case there is severe exposure during delivery, like there is a lot of mixing of blood during delivery, then we need to do a test which is known as KB test, Kleihor-Betke test. But when can this happen? When can severe exposure happen? So in case there is abruptio placenta, or during twin pregnancy, or if we remove the placenta manually, then there are chances of higher amount of blood of fetus mixing into the mother's blood, right? So at that time, if that's the case, we do a test which is KB test, Kleihor-Betke test. So do you remember we talked about APT test in the third podcast? Okay, so the principle of KB test is similar to that of APT test. So the fetal hemoglobin HbF is resistant to alkali as well as acid, but the mother's hemoglobin, which is Hba, is not resistant. So we use this principle. We take out mother's blood, we add citric acid to it. So when we will add citric acid, the mother's RBC will get hemolyzed, but the fetus RBC will remain intact. Now we take this on a slide, see it under a high power field, and count how many fetal RBCs are there. Right? If we see 20 RBCs, that means 1 ml of fetal blood has been passed from the fetus to the mother. Likewise, we count the number of fetal RBCs we can see, and then predict the amount of fetal blood that may have gone into the mother's body. Okay, so 300 microgram which were given initially, that 300 microgram was for 30 ml. So that 300 microgram was able to neutralize 30 ml of fetal blood. Okay, so now if we do a KB test and we get to know that 40 ml has been transfused, has been gone from fetus to mother. So how much dose we will give to mother? So for every 1 ml extra, we add 10 micrograms. So for 30 ml, it is 300 microgram. For 31 ml, it will be 330 micrograms. Okay, let's see a case and then we'll understand it better. So there was a female, primi gravida female, Rh negative, ICT negative. KB test was done, and 40 ml of fetal blood, it was found that the 40 ml of fetal blood is present in the mother. So tell me how much dose of anti-D should be given to this. Okay, this is case 1. Let me know the answer. The case 2 is similar case, primi gravida, ICT negative, KB test done, and after doing KB test we found out that 25 ml of the fetal blood is gone into the mother. So now how much dose should be given? So two cases, in the first case 40 ml, in the second case 25 ml, right? And so you tell me the answer for these two questions in the comment box. Now when do we terminate this ICT negative pregnancy? At 40 weeks, right? So this was about the management of ICT negative pregnancy. Let's come on to ICT positive. ICT positive is mother is already having antibodies against D antigen. Okay, so ICT positive can be either low titer or high titer. Okay, low titer is 1:2, 1:4 or 1:8. Okay, these are the low titers, and so this low titer group is also known as category 2. And if the titers are high, that is 1:16, 1:32 or 1:64, etc., then it is called category 3. So what does 1:2 mean? That if the dilution is 2 times, then one part out of that is antibody. So obviously 1:16 or 1:32 contains more amount of antibodies as compared to 1:2 or 1:4. Okay, because in 1:32, when we dilute 32 times, then even then one antibody is present, right? So 1:16 is known as critical cutoff. If the titer is 1:16 or more than that, then it is called high titer, and less than 1:16 is known as low titer. Okay, so now let's see how can we manage low titer or category 2 patients. So in category 2 patients, we keep on monitoring ICT every 4 weekly till she reaches 24 weeks, and then every 2 weekly thereafter, and keep on monitoring whether these titers are going into the high titer or they are remaining the same. They are remaining below 1:16. And if they remain below 1:16, then we terminate the pregnancy at 37 weeks. Okay. Now let's come on to category 3. If the patient is having high titer, then how can this affect? Like, what will be the ill effects of this high titer? These antibodies can pass through the placenta and can destroy the RBCs of the fetus. So there can be hemolysis in the fetus, there can be CCF, congestive cardiac failure, and hydrops fetalis. So for this, for high titer cases, for category 3 cases, we do two things. We monitor MCA Doppler, middle cerebral artery Doppler, and we do USG. What's the use of this MCA Doppler? So see, there is hemolysis in the fetal RBCs, or in the fetal blood there is hemolysis. So the patient will have anemia, the fetus will have anemia. So therefore there will be hyperdynamic circulation. And when we see peak systolic velocity on MCA, it can be increased than normal. It can be higher than normal. So if it is higher than normal, it suggests that the hemolysis is already going on and the fetus is having anemia. So the peak systolic velocity can either be normal or can be 1.5 times more, can be more than 1.5 times multiples of mean, okay, or multiples of median. So if it is normal, we manage it according to the category 2 case. But if the peak systolic velocity is more than 1.5 multiples of median, then we see the week of gestation. If it is 34 weeks or more, we immediately terminate the pregnancy. But if the baby is less than 34 weeks, then we check the hematocrit of the baby. If it is less than 30%, we need to give intrauterine blood transfusion. Okay, because we cannot deliver the baby before 34 weeks. So because the lungs are not mature, the brain is partly mature, so we need to anyhow extend the pregnancy till 34 weeks. So if the baby is less than 34 weeks, we check the hematocrit. If the hematocrit is okay, then we wait. But if the hematocrit is less than 30%, then we give intrauterine blood transfusion. Right? So this was about middle cerebral artery Doppler. Now we also do USG to check hydrops fetalis. So what will be the features of hydrops? There will be pleural effusion, pericardial effusion, there can be scalp edema. So scalp edema is one of the earliest signs and it is also known as Buddha sign. Okay, right. And there is one more syndrome which is mirror syndrome. So what is this? So in Rh negative pregnancy, the mother has placentomegaly and also she may suffer from PIH, pregnancy induced hypertension. So due to this, there is edema in the mother and also polyhydramnios. So even the baby is having hydrops fetalis and even the mother is having some kind of edema and polyhydramnios. So they are mirroring each other. That's why this is known as mirror syndrome. Right? And a last point here, one confusion I would like to clear. In some books it is mentioned that 300 microgram of anti-D neutralizes 15 ml of fetal RBCs, and in some books it is written that 300 microgram neutralizes 30 ml. So the difference here is that both want to say the same thing, but the first says that 300 microgram neutralizes 15 ml of fetal RBCs. Okay, 15 ml of fetal RBCs or 30 ml of fetal blood. Okay, it's almost the same thing because the hematocrit is around 45 to 50%. So either you can say 15 ml of fetal RBCs or you can say 30 ml of fetal blood. Okay, right. So that was it about Rh negative pregnancy. See you in the tomorrow's podcast. Till then, enjoy and keep studying. Bye bye.